Transposition, this one's my favorite. This is the only leftover diagnoses where the pre-op mortality and morbidity is higher than post-op. And it's really the foramen and the ductus that contributes to the problem. Literature, single center studies tell us what to look for the atrial septum and the ductus. This is a restrictive foramen with a tethered septum primum. The blood is just swirling around here on the fetal picture. This is what we call a hypermobile atrial septum. It's flipping back and forth. That's due to elevated left atrial pressure in utero. And here, the aortic and ductal arch. This ductal arch measures small. And then flow in the ductus should be only in one direction, but we can see that it's bidirectional. So certainly all these findings suggest that this baby's going to be sick in the delivery room, require a septostomy. These are high-risk patients. But the trick with and the difficulty with transposition is that if you see these features, it's very specific for difficulty in the delivery room. But unfortunately, if you do not see these features, you have about a 50-50 chance that the baby will be sick. So those aren't very good odds. This is an example of a case that I reported a long time ago now as a young attending. Showed up in my office at 34 weeks. Actually, in the OB's office, there was fetal distress with abnormal, horrible-looking heart rate tracing. And as they were prepping for a C-section, we took a quick look. The heart's dilated. The foramen is intact. And the ductus is gone. So this is transposition with the closed foramen and ductus. That results in a very sick fetus and a very sick newborn for sure. This is a really, really high-risk patient. We had ECMO in the delivery room for the section. There was cardiac arrest, right, with cord clamping. We were able to cannulate onto ECMO, and this kid did go on for an arterial switch operation, but unfortunately died from complications relating to pulmonary hypertension. Now looking at, so what do we do for these patients? Well, it's obviously ductal dependent, prostaglandin, that's the easy part. Stabilization strategy, 100% oxygen certainly is useful. You want those saturations to be as high as possible in the preductal area. You want PVR to fall. If they are very hypoxic and we're worried that the septum is closed, we actually do an echocardiogram in the DR. We'll intubate, sedate, and paralyze. And if there's reverse differential cyanosis with marked hypoxia in the preductal area, so saturations on pulse ox of less than 60, we will start nitric in the DR. Again, reassessment once the kid gets to the cardiac unit, once we've changed the circulation. Plan for the balloon septostomy. It can actually happen in the DR, in the ICU, or in the cath lab because we can do balloons using echo guidance. So here's an intact atrial septum with just a tiny connection down here. Pay attention to the balloon that's in the left atrium. It's accessed via the femoral vein. Push the balloon down across the foramen, blow it up, and then pull it across, and then an open atrial connection.